So the trial that I'll be talking about is called ENRICH Plus, and hopefully as we go through the subsequent slides, the reason for calling it ENRICH Plus will become evident. It's based on ENRICH, but it adds something else. So this slide summarizes just one point about the previous talk, ENRICH itself, and that is that basal ganglia patients in ENRICH were relatively few, about 92, I guess, total, some of which were best medical management and some of which was surgery. And as we've just heard, the trial was overall positive, but neither benefit nor harm of minimally invasive parafascicular surgery was identified for patients with putamen or basal ganglia hemorrhage. And that's where this comes in. So I believe, at least in my view, we have at least equipoise regarding MIPS in basal ganglia ICH. So just to step back a bit on some of the basic science, some of which was touched on in the last slide. There are basically three major mechanisms by which tissue damage occurs in intracerebral hemorrhage. There's, of course, the destruction of tissue by the hemorrhage itself. There's the inflammatory cascade complex that involves partly NF-kappa B, number of inflammatory cytokines, all of this resulting in edema, all of which can be harmful to tissues. But there's another pathway that is unique essentially to intracerebral hemorrhage in terms of types of stroke, and that's peroxidation and ferroptosis. And I wanted to take a moment to highlight ferroptosis as a mechanism of injury that we should be giving perhaps a bit more thought to in this disease. And as we proceed, you'll see that the thinking is that we should be targeting not only inflammation, which has been a dominant theme historically, but also peroxidation and ferroptosis in ICH. So this is a listing of recent and active trials in intracerebral hemorrhage. And the ones that, the agents that are yellowed out are basically agents that target some aspect of the inflammatory cascade. So we see the S1P modulators, the traditional one, fingolimod, the more recent one, siponimod. As you may know, siponimod was terminated early, actually during the pandemic, for futility. Now, there may be a positive effect from that trial, but the trial was terminated early for futility. A number of other agents, without going down the list, minocycline targeting reactive microglia, the COX inhibitors, statins, IL-1 receptor antagonists. All of those trials have been disappointing in many ways. The sulfonylurea glabanclamide, to which I'm very much a fan of, as you all know, that showed a positive effect in terms of shift at 90 days at favored drug, but in terms of the primary, that trial also was negative. The only two on that list, the only two agents on that list, deferoxamine at the top and pioglitazone at the bottom, neither one of which is yellowed out, are addressing the mechanism of ferroptosis that I'm focusing on now. So there's been a tremendous emphasis on trying to treat the inflammatory consequence of ICH, but so far without great success. Now, ferroptosis used to have the name oxytosis, but it was characterized as ferroptosis as recently as 2012, just a bit over a decade ago. So it's a concept that's, in relative terms, somewhat new. It's a type of programmed or regulated cell death. It's induced by excessive oxidative stress, which is particularly prominent in intracerebral hemorrhage. It's dependent, highly dependent on the accumulation of iron, which of course is coming from blood. It's characterized by the accumulation of lipid peroxidation. And key here is that it's regulated by glutathione peroxidase 4, GPX4. So it's genetically and biochemically distinct from other forms of programmed cell death, some of which we're all much more familiar with, apoptosis being the most obvious prominent example. And I want to emphasize again that it's the most important form of cell death in hemorrhagic stroke. So if that's the most important form of cell death, either oligodendrocytes in critical white matter or neurons, attacking inflammation, as important as that is, and I'm not dismissing it, won't address this aspect of the secondary injury, ferroptosis. Lipid peroxidation is a crucial mechanism that directly initiates ferroptosis, and it's a process whereby oxygen is binding to lipids to produce these lipid peroxides by forming peroxyl radicals. And as I mentioned before, the most important protection against ferroptosis is mediated by glutathione peroxidase 4, GPX4. And this enzyme converts lipid peroxides into non-toxic lipid alcohols. So if it's absent or depleted or not functioning, those peroxides built up. And ferroptosis is initiated by the failure of these glutathione-dependent antioxidant defenses, resulting in the unchecked lipid peroxidation and eventual cell death. So very important aspect. And here's a sort of a cartoon representation of that. You see in the middle GPX4 being driven by glutathione, and that bar indicates that it is inhibiting or preventing this lipid peroxidation. So without GPX4, lipid peroxidation occurs and ferroptosis occurs. Also shown here is the fact that vitamin E as well as CoQ10 are alternative pathways for getting to inhibit this lipid peroxidation. But again, the key one, GPX4 and glutathione, very important pathway. Now, when you look at the basic science literature, you can find a whole number of ways to inhibit ferroptosis. And here is a fairly comprehensive list. Don't need to go into any detail on this entire list, but the targets of these different drugs are iron itself, as you can see in the left, reactive oxygen species, GPX itself, as I've emphasized already, is obviously an important target. And another one that I'm fond of is Pipar gamma, the nuclear transcription factor that we'll give some consideration to. Now, the list of agents, drugs that address these various targets, all of which are aimed at inhibiting ferroptosis, that whole list includes only 2 agents that are prominent and FDA approved, and those are obviously deferoxamine and pioglitazone. Now, a lot of these others may or may not be of interest somewhere down the line, but in terms of repurposing available FDA-approved drugs, the 2, deferoxamine and pioglitazone, are 2 prominent ones that address this concept of ferroptosis. We'll focus on pioglitazone because it is uniquely pleiotropic in terms of addressing the various mechanisms of injury, including separately ferroptosis, separately inflammation, as well as ridding blood from the scene by enhancing erythrophagocytosis by biasing macrophages towards the M2 phenotype. So I credit Jarek Aronofsky in Houston with getting us thinking about addressing intracerebral hemorrhage in this manner. So he published several years ago, Annals of Neurology, the Pipar gamma agonist approach to ridding blood. And these are images from that paper showing that with rosiglitazone, which is a Pipar gamma agonist related to pioglitazone, that the resolution of blood is accelerated in the animal model of intracerebral hemorrhage. He also showed in that same paper this mechanism of erythrophagocytosis being enhanced by a Pipar gamma agonist. And you can see in the upper portions the colored images showing microglia or macrophages that have been stimulated to exhibit this M2-like phenotype. And you see these little inclusions within the macrophages in the panels E and F, for example. Those are erythrocytes that have been phagocytized and are within the cell. So we as surgeons are removing the hematoma, but with the hematoma that's left, the macrophages are then removing the remainder of that hematoma, and that process can be accelerated so that the erythrocytes are phagocytized before they lyse, before they release their neurotoxic components, hemoglobin, heme, and so forth. In those bottom panels, you see two drugs, the PGJ2 in the middle, I panel, and J, the rosiglitazone, both of which are activating Pipar gamma, accelerating phagocytosis of blood. So just to mention, this PGJ2 is the intrinsic or endogenous agonist of Pipar gamma. And of course, rosiglitazone and pioglitazone are both pharmacological agents. Beyond simply accelerating the removal of blood by promoting erythrophagocytosis, Pipar gamma activation also directly antagonizes the process of ferroptosis. And this is shown in a separate paper by a different group with ferroptosis induced by either elastin in the upper panels or by heme, the product of blood hemolysate in the lower panels. And you see the red curves in both are showing that increasing concentrations of pioglitazone in this case, antagonizing this process of ferroptosis. So independent of removing the stimulus for ferroptosis, ferroptosis itself is being inhibited by Pipar gamma agonism. Very important concept. In addition to that, there is direct anti-inflammatory effect of pioglitazone. This is work from our lab on activated macrophages that are being shifted from an M1 to an M2-like phenotype, as exemplified by the fact that they are having less activated nuclear factor kappa B, P65 in the nucleus, less INOS, inducible nitric oxide synthase, responsible for nitric oxide, and more arginase, which is a marker of the M2-like phenotype. And you see in the bottom portion of that increase in phagocytosis of these activated macrophages with the M2-like phenotype. So three important mechanisms: removal of blood, enhancing erythrophagocytosis, reducing inflammation, and promoting or inhibiting, I should say, ferroptosis by this Pipar gamma agonist approach. So that's summarized in this slide, these three beneficial effects independent of Pipar gamma agonism. So the other thing that the Houston group initiated was a small clinical trial on this Pipar gamma agonist, pioglitazone. This was headed by Gonzalez, who worked with Aronofsky. And this was a small phase 2 dose-finding safety trial, not powered for efficacy, but they did give the drug, PO, to patients with intracerebral hemorrhages, again, with the concept of establishing safety and determining maximum tolerated dose, which they found to be 1 milligram per kilogram per day, a little bit more than what's used in patients with type 2 diabetes. So On those grounds, based on the basic science that I've briefly reviewed, and the fact that there's already been safety established specifically in ICH patients, not only in diabetic patients, but in non-diabetic patients of this drug, we proposed ENRICH Plus, which would be building upon ENRICH itself, but adding this pharmacological agent to see if we could improve outcomes in patients with basoganglia hemorrhages. So basically, the concept is that we want to combine the most promising surgical approach, which now I would say is MIPS for ICH, combine that with what I consider to be one of the best pharmacological agents to try in this context. The trial itself is currently designed as a small pilot feasibility trial. It's focused exclusively on basoganglia patients. It is otherwise the same as ENRICH Plus in terms of inclusion and exclusion criteria, and it has the same exclusion criteria that the shrink trial on pioglitazone in ICH had, so that we can then combine the results of the patients with basoganglia hemorrhages who received surgery only in ENRICH and compare them to patients who have surgery plus receive pioglitazone in the ENRICH Plus trial. So our plan is to do Euclidean matching using Pipars based on certain demographics of patients in the ENRICH trial to match to those in ENRICH Plus. We have the same outcome measures and the same secondary efficacy goals without going into too much detail there. Again, this is a long list of inclusion-exclusion criteria. The important point is that it matches what is already, it matches the inclusion-exclusion criteria of the ENRICH trial in terms of age, location being the major exception. I think I skipped one. Yeah. So we have an IND for the use of pioglitazone in these patients with ICH, and we've been through all of the bureaucratic paperwork, and we've begun to enroll. And I just want to show you very briefly, the first patient was a 43-year-old lady who presented to an outside hospital with an acute headache, left facial arm and leg weakness, and was intubated for worsening neurologic status. And that's her exam. She had a flaccid left hemiparesis. This was her admission scan at the outside hospital. And I show you that. She was then transferred, and we rescanned her at the University of Maryland, where she was enrolled in the trial. And as you see that during the interval between these two scans, her hemorrhage enlarged considerably. She underwent MIPS surgery, and this is her post-op scan showing a reasonable result with decreased mass effect and good resolution of that hemorrhage. And of course, she received drug. So this is my last slide. The concept here that I'm endorsing is that surgery alone is not enough. SANE, S-A-N-E, surgery alone is not enough. And that's the idea behind ENRICH Plus. Surgery may be enough in lobar hemorrhages, as we've seen in the previous presentation, but it's not clear that it's enough in the patients with basoganglia hemorrhage. They need more. And I think we need to consider addressing the different mechanisms of secondary injury, as we've reviewed inflammation and the resultant edema, very important to address that. But in addition, need to address lipid peroxidation and resulting ferroptotic cell death that ensues. Thank you.
Thanks, Dr. Simard. Outstanding work. It's always motivating to see neurosurgeons dive into and delve into the basic science, and your expertise really shows that. Following on Gustavo's talk about the clinical trial, clinical science. So we look forward to this extended version with ENRICH Plus. Any questions? Amin?
Some of us are starting to explore NF-kappa B modulation as well. What are your thoughts on using that as a synergist to reduce inflammation, particularly with, we're seeing some extraordinary results with BRAF coupled with MGMT, and all of those pathways are likely immune modulated.
Yeah. I didn't hear what compound, you were just picking up the microphone.
Just looking at NF-kappa B
Oh,
modulation.
NF-kappa B. Yeah.
As
Sure.
a synergizer. Obviously in a trial, you can only have one.
Yeah.
A lot of us are looking at NF-kappa B.
Right.
The other arm of your process.
Yeah, I think critically important. I showed you that pioglitazone is also a prominent inhibitor of that pathway, also with 50% or so reduction in these activated macrophages of NF-kappa B. I think attacking both of those arms, the inflammation arm as well as the ferroptosis arm, are very important. I think the key is that the inflammation doesn't get to ferroptosis. And so attacking both is I think is key.
I think you've also explained scientifically what many of us have seen intuitively. Less than 15 cc's volume matters and residual time matters. I think you've finally given us the science behind that. So thank you.
Yeah. Thank you for that comment.
Anyone else? Any other questions? Comments? Thank you again. Very motivating. Appreciate all that work and look forward to hearing the results of the trial.